Well, we go out a little bit from strictly speaking of competence and patients. And I would like to present what is a joint work. It's not only I'm involved in the project more as a participant to this project than as an organizer. I'm also involved in some meetings as an organizer. I'm going to show you what I find a really, really interesting initiative from E&M. They have a lot of great success all abroad, and not only in Europe, also otherwise in the world. It's about the EARL project and PETCT imaging standards for clinical studies. Some disclosure because we support this study from Philips and Roche, and some part are also the work of other people, E&M people, and also Office E&M, EARL team, and some other people, not only my team. So we will talk about quantitative results of imaging biomarkers, standardization and quantification in PET-CT, how we move from guidelines to EARL accreditation, multi-center harmonization and quantification, possible future direction, and practical aspects involving technologies, and eventually discussion about this topic. So what's considered biomarkers? Are some physical entities images that can be measured and used to indicate a biological process, disease process, or drug response. A surrogate endpoint or marker is a laboratory measurement of physical sign used in therapeutic trial as a substitute for a clinically meaningful endpoint that is a direct measure of how a patient feels, function, or survives, and it expects to predict the effect of the therapy. So, what do I say? FDG is a kind of surrogate marker, it's a biomarker. That's what was said also before in the conference. FDG is really, it's not only for diagnosis, but it's also great help for therapy assessment, for therapy experience. So you can see how different radiopharmaceutical image different metabolic pathways like biological characterization, diagnosis, therapy, response evaluation, and also restaging of some disease. We have the most common standardized quantitative measurement is SUV. This is about activity concentration ratio, about the dose and weight that we have. Sometimes weight is substituted by BMI or BSI. It depends from every center. So the use of SUV and response assessment study. We can use absolute SUV as for patient eligibility, patient stratification, selection of the lesions, and also for the residual SUV. And so we can use relative or percentile of short chains. All these are quantitative use to deal with the response assessment of a therapy. What does it mean? We give a therapy to an oncological patient. We want to know really how much it works, this therapy, and we use SUV as a quantitative point to help us in decide how much he responded to the therapy or not. Is I'm going to show you about what is the chain of process of quantitative biomarkers. You can see there is a scale for a single patient, single scan, and also there is a comparison between scans. This is all the chains that we do for imaging biomarkers. So what does it mean? That for standardization and harmonization, we need to have guidelines or procedure to address user or several related factors, requirements for imaging data acquisitions, rules for image data analysis, and criteria for data and response interpretation. We are always talking about standardization and harmonization of images. What does affect PET imaging? It's quite connected with the discussion about artifacts. So there are technical factors that can really affect SUV measure. Like, there is a relative calibration between pen scanner and dose calibrator. There is a residual activity. Someone today talked about the problem of residual activity in syringe. Incorrect synchronization of clocks. Injection is different versus calibration time. And the quality of administration. If there is a really out-of-vein injection, SUV can really be affected. Are some physics-related sectors like acquisition parameter, image deconstruction parameters, the use of contrast agents, we talked about it before, and also when we do the region of interest, that can change how we measure SUV. So are some biological factors like uptake period, patient motion, and blood glucose level. These are not only about having artifacts, it's about that really can affect the measurement the quantitative measurement, because sometimes you can still read, a physician can still read well image, but if you go to quantitative assessment, you will really see big changes about it. This is an example for patient preparation. You know, with high glycemic situation, we have low glycemic, the same patient, as you see how different is the, also you see qualitatively how different is the lesion. And then, so scan acquisition, you can see how can change SUV when it is changed the time in which the patient is scanned. So SUV, when you scan the patient at the beginning, right after injection, or you scan it really late. SUV may change really, really widely. There are some studies that are talking about pulmonary malignant disease. Image reconstruction, you can see how can really change about how many iterations we use for PET reconstruction. This really can bring a really big change with that. And also imaging interpretation. Sometimes when you have also physician can interpret in a really different way the SUV. So there are guidelines that state the SUV is in some point or some point, how we perceive SUV as a measure of what's going on. So for example, it's about endpoints, to decide that this recurrency is the therapy is good or not, depend. Sometimes it can depend for interpretation. So what do we want to say? That we need consistency of the execution of imaging procedure in a longitudinal setting. To be sure to have an exam that is reproducibility, that is comparable, you have to have a consistency. You need to have standards. Standardization and quantification. If you want to go to personalized management of cancer, you have to use specific data. Molecular imaging techniques can be used to study several tumors. And FDG PETCT has been proposed as a surrogate biomarker for monitoring cancer therapies. There are several radiopharmaceuticals other than FDC, with the potential to characterize tumors and monitor to response therapy. Imaging biomarkers must be standard and quantitative if we want to go into clinical trials. So what we require? Repeatability in one patient using the same PETCT system. Reproducibility between patient, system, and institution of performance, analysis, and interpretation. Implies standardization and harmonization of information procedures are essential. Without them, we cannot compare studies. Simple. Here are some guidelines from ENM. And what are made for? Minimizing physiological and biological effects by patient preparation guideline. We prepare patient well, we can reproduce it. Procedure to ensure accurate FDG administration. We have to administer it well. Matching of PET-CT study statistics by prescribing FDG dosage as a function of patient weight, type of scanner, acquisition mode, and scan duration. We need to give the right dose to the patient for what we are going to do. Matching of image resolution, so we have the same parameter. Standardization of data analysis by prescribing region of interest strategies and SUV measure. You need to know how to measure before having good standardization. And also we need multi-center QC and QA procedures for PET and PET scanners. That's what we are going to do. After the guidelines stating that, we say, here is the point that we can go further. Not enough guidelines, we're going to go further of that. EARL Accreditation, how it works. You must express interest through the EARL website, send written agreement to comply with FDG PET-CT guidelines, so you have to accept these guidelines, fill out a questionnaire, and then perform QC experiment as described, like some manual, some calibration QC, and some also image quality, and serve recovery performance. Here are just some, it's not advertising because I don't have any money in saying that. And so there is some more information about the website. How it works? The accreditation works with a calibration QC made 4 times a year, image quality SUV recovery 1 time a year. As you can see, the accreditation fee is really low, and also is free for the first year for newly started PET-CT system. It's not something made for money. It's made for the sake of having standards quality all around Europe. And also we have signed it for that, obviously. How do it work? Standardization. Quantification as a combination of image resolution, noise, and data analysis method. LQC based on exploration to find highest common denominator in performance of scanner, SUV recovery, and transition to SUV peak. Scanner performance harmonization is feasible on a large scale, but long-term sustainability requires support and service from vendors. It's a goal of both KSNMMI, CTN, and EARL. Just to tell you, this standardization is still a joint work between us and the KSNMMI. So they are working, and there are a lot of scanners created up now. You think there are about hundreds of scanners, about 150, I think. The largest procedure made for CT scan took about 20. So this, we are really much more standards than what are CT system. So how it works? We have to perform the QC standard procedure system, like the system and the manufacturer says. Calibration QC using cylindrical phantom. Adjusted NEMA image quality procedure. A CT QC recommendation like national law. And also the other control that you do regularly for your scanners. What is focused? The EARL part is focused about the two parts, calibration QC and NEMA. So available, there is a standard operation procedure, so how you have to perform calibration QC. We use a cylindrical phantom about 20 centimeters, and you must know accurately which volume must be. You have to prepare about 70 megabecquerel FDG in a syringe, and you have to measure exactly how much is there. Insert the activity in the water-filled cylinder, yes, for water-filled, and measure the residual activity in syringe. After you have prepared your patient or phantom, then you have to make a PETCT scan, two-bed position of at least 5 minutes. Reconstruct data with a specific reconstruction setting suggested, submit to EARL, and then EARL verify if the average SUV is correct. We have must be perfectly correct. We have 10% possible variation between the value. Here are some images of how it looks like. This is calibration QC image that we performed in our center. Also, this is quite more tricky because we are talking about. Do you know how is the NEMA Phantom? Have you ever seen one? NEMA Phantom is like a phantom. It's made of about a little sphere inside. And also we have a standard operation procedure for that. It's quite more difficult to do than a calibration QC. Like you see it. Used to use a accredited NEMA Phantom, but also if you want to be part of the project, it's a common practice to rent it if you can provide it. And also you have to stock solution for the sphere, and stock a solution for the background. You know, inside the Phantom there are a lot of spheres that you have to fulfill with a solution of FDG, and then you have to fulfill all the background. And you have to measure the residual activities in syringes. With both calibration QC and image quality, it's really important to have a correct distribution of FDG inside the phantom background compartment. You can see my colleagues that they are washing it, because we have to be sure to be a correct background. Then you make the usual two-bed studies, reconstruct data, and you can use also the settings that are suggested by EARL. And also we have to follow the tide soap and report forms. This, you can see here, it's quite nice. You can see all the spheres and the backgrounds, how it works. You can check how many spheres you see, about knowing exactly what is done. You have an idea of how much will be. Well, you look like it simulates a body, part of the body, the lung body. You can also have some artifacts based on reconstruction. And this also can give problem in measuring the SUV max. Can be problem of reconstruction, can be always problems of preparation, the phantoms, because sometimes it happens that you have not the perfect background, you have not the perfect fulfilling in the spheres, so you can have reconstruction. No problem, do it again, just a simple situation. Here you can see a software analysis of how it is. And that measure, there is a program that measures all the details, void, calibration, and so on. And this is a curve of what's happening. You see, you check the points, the small points that are inside the two. This doesn't mean that this calibration is correct. You can see how the standard is. So also there are plus or minus 10% recovery. And the recovery specifications are also for SUV max and SUV min, since both are used for clinical studies. As you can see, sometimes there can be errors, sometimes there will be not a perfect study. No problem, they just keep the accreditation on hold. Please do it again. The most important things, and if your machine doesn't work, there can be only 2 points. Or you have done things wrong, or there is a problem with the machine. And this could be a really, really good standard to understand if your machine is working correctly. Can be really a good help. You see, the first studies, the first test, how a lot of systems were outside. Accredited sites are quite more homogeneous than that. And also it happens the same with the quality, how it was before accreditation, how it is after. You see that tomograph met standard quite better than that. But it's not so impossible. Doesn't think that every PET scanner can really achieve accreditation. It's not for only the newest one. It's for everything, PET scanners. As you can see, there is a really small difference between vendors. Not so difference changing at that. So what we are going on is about having more of that and having this procedure approved by most of Clinic Australia. So for, again, we love the terms lobbying to have this kind of standardization used for that. So some recommendation for technologies involved in accreditation. Phantoms are your best friends. So you have to love your phantoms really. And not enough, because teaching is important. You have to teach your colleague to love the phantoms, because without them you cannot do anything. So you have really to take care of your phantoms. Be sure that he's healthy. Be sure that he's really help you. And also sometimes you have to take care of your mental health, and I really help my colleagues for doing that. So thank you very much for that.
Your center, how often do you do the SUV?
Well, we just follow we have 2 tomographs, and we follow both the schedules, because we do 4 times a year the calibration, and one time in a year the NEMA quality system for both tomographs. So yeah, and that's not just one. Every tomograph is accredited by himself. But what I want to say that well, in some centers that is done by physicists, but actually I did it. So I think every technologist may do it, and it's quite like a technologist job. That is not patients, but it's a job that is about scanning. It's about preparing the pharmaceutical. It's about fulfilling phantoms. So there is no problem. I think there is a really a good point to help, and it's also quite like educational, because you learn how really your machine works. And you really, which kind of imaging, the quality of the imaging that you are performing. So it's quite nice for technologists. It's really appealing, in my opinion.
When you mentioned about the quality control, 4 times a year, and for the image quality is 1 time a year. Okay, is it being done by the technologists themselves, or because actually here in there are certain quality controls, but it's being done by the vendors themselves, by the vendors' engineering, right? Engineers. Yeah. So. Yeah. Yeah, for the daily quality control, it's being done by the technologists, but there are, as I said, which is the annual one, it is being done by the vendors themselves. So is it the same thing?
It's not quite the same thing. Well, what we are doing is all the quality that you usually do must be done. If you have some quality controls made by vendors, you also have to be done. It's about a third party. You know, just to explain you what is happening with clinical trials. If you have to be to assess a response therapy, you have to know if there is really a response therapy in every patient, and to have the same standard for that. What does it mean? If you want to use PETCT as an indicator, you have to be sure that this PETCT is made using some quality standards. So what we do between the people that are doing clinical trials and the vendors. And there is a third party that states, using quality control and calibration accuracy and image quality, they state that in this center you are performing PET scans with a certain standard about that. So it puts inside and say, may you use your center for Kuwaitan center or American center or Arabian center or Italian center as a study? Yes, you can do a study all together because they are all performing PETCT with the same image quality, and there is a third party stating that. But also they meet their standards, so they do the calibration, they do their homeworks, everything. That is all part of the quality standards.